Good afternoon and welcome to the Alliance for Home Health Quality and Innovations webinar on the Home Health Chartbook, Updated Data and Trends for Home Health Care in the United States. My name is Teresa Lee and I'm the Executive Director of the Alliance for Home Health Quality and Innovation. By way of background, the Alliance was founded in 2008 and is dedicated to the mission of leading and fostering research and education on the value that home health care has to offer to patients and the entire healthcare system. Our webinar today will focus on the compendium of data that the Alliance commissions on home health care in this country. The Home Health Chartbook was commissioned by the Alliance from Avalere Health, a healthcare consultancy that works with healthcare stakeholders to improve care delivery through better data, insights, and strategies. We're very fortunate today to have as our guest speakers Ellen Lukens and Lily Hummel of Avalere Health. Ellen Lukens is the Vice President at Avalere Health and provides strategic support to a broad array of clients interested in better navigating the current and future hospital and post-acute care delivery and payment environment. Before joining Avalere, Ellen worked for the National Association of Public Hospitals, the Greater New York Hospital Association, and the Centers for Medicare and Medicaid Services. Lily Hummel is a senior manager at Avalere Health, where she advises clients on regulatory and legislative developments in the post-acute and long-term healthcare sectors. Before joining Avalere, Lily was an analyst with the Government Accountability Office, and she previously worked with the Wisconsin Legislative Council and the Population Health Institute. Just a few housekeeping notes before we get started. First, Ellen and Lily will speak for about 40 minutes, and then we'll leave the last 15 minutes to answer questions. Please note that this is a webinar and we control the slides on our end, so don't be surprised if you are unable to flip ahead. Second, your lines will be on mute. You can submit your questions to be answered during our Q&A period through the Fuse webinar software on your computers or other devices. You can also send a question to the speaker to be answered in the Q&A period by sending a question to me, Teresa Lee. And finally, we'll be posting the slides on the website after the webinar, and we're also recording the webinar and we'll post the playback on the Alliance's website when it's available. With that, I'm going to turn this over to Ellen and Lily.
Thank you, Teresa. Hi, everyone. Thank you for joining us this afternoon for this call. I'm Ellen Lukens, and as Teresa said, I lead our provider practice at Avalere Health. As Teresa noted, the purpose of the call today is really to walk you through some of the research that Avalere Health conducted on behalf of the Alliance for Home Health Quality and Innovation. And really the goal of this research was to better understand how those Americans using home health services, how they, sort of some of their socio-demographic perspective as well as their clinical profile. And just as an example, our findings show that home health users are more likely to be older, racial ethnic minorities, more likely to be women, have more chronic illness, and also have lower incomes. And I think this is a particularly important topic given the evolving healthcare landscape. You know, as we think through some delivery and payment system innovations, I think really understanding who patients are who are using home health services as well as some characteristics of the agencies is very helpful. So we're going to share the research with you and then open up the line for questions. As you'll see as we go through the chart book, we're not going to walk through every slide. We'll just highlight some key findings. But as Teresa said, the slides will be available for download, so you can get the comprehensive slide deck. And at the end of the presentation, we've also included Lily and my contact information, and you can always reach out to Teresa and Jen as well from OCLI with any questions. So with that, we'll start with section 1, which is the national overview. So section 1 provides an overview of the demographics of the home health population. And it really profiles the home health population, and by that we really mean the Medicare home health users, really contrasting those to all Medicare beneficiaries on demographic characteristics, such as age, race, ethnicity, gender, income, dual eligible status, and those home health users with severe mental illness. So we're going to start with slide 1.7. So this slide is a summary table that provides a snapshot comparing characteristics of Medicare home health users and all Medicare beneficiaries. You'll see that home health users are much more likely to be elderly and live alone. In addition, home health users are more likely to have 3 or more chronic conditions, have 2 or more activities of daily living limitations, and report fair or poor health. Further, more home health users have incomes below the federal poverty level. So if you look at those bottom 2 rows, we look at folks who have incomes that are under 200% of the federal poverty level or under 100% of the federal poverty level. And what this slide shows is that 67% of all Medicare home health users have incomes below 200% of the federal poverty level. 31% have incomes under 100% of the federal poverty level. And if you think about what does that actually mean, if you look in the footnotes, 100% of the federal poverty level for a household of 1 was 11,490 in 2013, which is the data that we used here. So I think what's really important here is really understanding that 67% of Medicare home health users are low income, and we start to think about potential policy proposals around increasing cost sharing. These are some metrics that I think and variables that are really important to keep in mind. Chart 1.8 uses actually a different data source. It's the Bureau of Labor Statistics, and it shows annual living expenses for households with incomes under 200% of the federal poverty level. And I think the point here is just that healthcare out-of-pocket costs already represent a substantial proportion of low-income Medicare beneficiary spending. So again, just when we're thinking about policy proposals, really having that context of understanding who are the folks that are actually using these services and what do their incomes look like. So I'm now going to turn to chart 111. And this is another summary slide, and what this shows is that there's a higher percentage of Black and Hispanic home health users that have 3 or more chronic conditions, and a much higher percentage have 2 or more ADLs. Black and Hispanic home health users are also more likely to report fair or poor health and being in worse health than last year. Chart 112 on the next slide shows that a higher percentage of Black and Hispanic home health users have incomes under both 100% and 200% of the federal poverty level when compared to all home health users. If we move ahead to chart 117, we see that the dual eligible status of home health users versus non-dual eligible home health users. The chart shows that dual eligible home health users are more likely to have 5 or more chronic conditions. A variety of conditions are labeled as chronic conditions. Those would include things like high blood pressure, arthritis, diabetes, heart failure, and Alzheimer's. But I think what this shows is, dual eligibles, the profile of dual eligibles, they do have more complex clinical conditions and certainly more clinical conditions. And if you look at the blues, you see the proportion, almost 75% of the dual eligibles have 5 or 4 or more comorbidities. So I'm now on chart 120. And the final portion of this section gives an overview of the proportion of home health users that have severe mental illness versus the overall Medicare home health population. As you see in this chart 120, Medicare home health users with severe mental illness are more likely to have 3 or more chronic conditions, 2 or more activity of daily living limitations, report fair or poor health, or report being in somewhat or much worse health than last year. I'm now on chart 122, and what you see here is that 27% of the home health population has a severe mental illness versus 18.7% for the overall Medicare population. And I think for those of you who've been tracking some of the articles and sort of anecdotal discussions around some of the alternate payment models like accountable care organizations, a lot of people are now really focused on this population because their spending is higher and trying to understand how do we better manage Medicare beneficiaries with severe mental illness. I'm now going to turn to chart 124. You'll see a new slide we added this year, and we're summarizing selected characteristics of home health users from 2010 through 2013. We see an overall increase in the percentage with 2 or more ADL limitations, and the percent under 100 and 200% of the federal poverty level. Over time, the percentage who are duals or who have severe mental illness has increased slightly as well. And I think this temporal view will be increasingly helpful over time as we understand how these conditions and also characteristics are evolving. So with that, I'll now turn to Section 2. Section 2 is the clinical profile of home health users. On chart 2.1, you'll see the most common hospital MSDRGs for beneficiaries who are subsequently treated for post-hospital care by home health agencies. So by this we mean that these are folks who were admitted to a hospital for an acute care episode, and these are the conditions for which they're most likely to be transferred to a home health agency. So we reviewed a 100% sample of all beneficiaries who had hospital admissions in 2013, and we linked those with home health claims to see who received home health services following the hospital admission, and for those beneficiaries that did, what their hospital diagnosis was. And what you'll see in this chart, the most common MSDRG is major joint replacement or reattachment of the lower extremity without major complications or comorbidities. This represents nearly 10% of all hospital cases referred to home health. This is particularly interesting because these cases for DRG 470 will be included in the proposed comprehensive care for joint replacement model for 75 selected MSAs beginning next year. So as many of you know, CMS has proposed a mandatory joint bundle. It's not finalized yet, but if it were to take effect, it would take effect January 1, 2016, and it would include this top condition for which home health agencies are treating beneficiaries. There are a total of 753 MSDRGs. 38.4% of those are for home health cases are concentrated in the top 20. So what you see here is nearly 40% of the total home health volume that is coming out of hospitals. So please note that this represents 100% of those cases that go from acute care hospital to home health. It does not include, obviously, those that enter from the community. Chart 2.2 shows the primary diagnosis on all home health claims. And what you'll see here is that 8.64% of home health claims include a primary diagnosis of diabetes, which is down slightly from last year, but remains the top primary condition. And we thought this was really interesting and really speaks to the point that home health really has a really important role in post-acute care, but also probably in chronic care management, given some of the conditions that are in the top 20 here. Chart 2.3 shows the prevalence of multiple chronic conditions among home health users. So we analyzed the Medicare claims to identify those beneficiaries that had 3 or more chronic conditions and used home health within the year. We compared the beneficiaries against the total Medicare population. And what you see is that home health users are substantially more likely to have 3 or more chronic conditions than all Medicare beneficiaries. The prevalence of 3 or more chronic conditions varies state by state, from around 80 to 90%. But in all states, the prevalence is much higher than for all Medicare beneficiaries. And one thing I just wanted to note about this that I found really interesting is if you look at the home health users with 3 or more chronic conditions, you see that they vary somewhat among the states, but not at all as dramatically as those without the percent of Medicare beneficiaries. So if you look, for example, at Hawaii, the percent of home health users with 3 or more is still very high. It's still at 85%. But if you look at the general population, it's only 10.8%. So there really is a big difference among the Medicare beneficiaries with the percent of just Medicare beneficiaries on the whole with 3 or more chronic conditions. But if you look at the home health users, they're fairly consistently high across all the states. So I'm now going to turn to Section 3, which is a post-acute care market overview. And I'm going to start with chart 3.2. So Section 3 is really designed to provide an overview of the post-acute care market and to provide some context about the home health industry. So on chart 3.2, what we're showing here is the distribution of the discharge destination for all Medicare patients that had a hospital stay. So what we mean by that is after a hospital stay for 100% of Medicare beneficiaries that were in the hospital, and again, our data is from 2013, where did they go after that hospitalization? And you'll see that in 2013, 38% of all Medicare beneficiaries got some kind of formal post-acute care. And you had 56% that went home to the community with no home health. 3% died, and 3% received care in some non-post-acute care setting. And examples of that would be something like a specialized hospital, like a cancer hospital or psychiatric hospital. Of the patients discharged from the hospital, 14%, or 1.4 million, received home health services. And I think this really underscores the important role home health does play as a post-hospital partner, helping Medicare patients transition from their acute care hospital stay to their homes. On chart 3.3, we look at trends and trends over time. And I think this is particularly interesting given a lot of what is going on now, but I'd just like to highlight a few things here. The first is, if you look at total, I think the most striking change in this graphic is the decrease in total hospital stays that are Medicare covered between 2011 and 2013. So that decreases by almost 700,000, which is a pretty substantial decrease. So I think that's the most notable trend here. I think we also see that actually the pattern within the folks that were discharged continues fairly consistently across those 3 years. So you have home health representing 13% in 2011, and then 14% in 2012, 14% in 2013. I think these trends may change over time, and we may see more volume into home health over time. And the reason I'm saying that, and again, this is based on anecdotal evidence, is that the initial report, which was based on a very small sample from BPCI, did show that hospitals in the bundle payment for care improvement program were shifting more volume to home health. Again, that was based on a small sample, but assuming that that behavior is consistent and CMS implements the comprehensive care for joint replacement, I think we may see more volume shifting into home health. I think the other thing is that there have been other articles and anecdotal stories about some organizations, the New Jersey hospitals come to mind, where they've talked about how for specific conditions they have shifted between settings. So I think if we look at 2014, 2015, 2016, we may see more change over that time. But again, I think that change in the hospital Medicare volume is really substantial and is notable over this time period. So charts 3.4 through 3.7, and again, you can download all of these charts. We're really just trying to highlight some of the key findings. These show initial patient destinations, and again, that's where somebody went right after their discharge. And we used regions as defined by the U.S. Census Bureau. So the states are categorized into 4 regions: Northeast region, Midwestern region, Southern, and Western. And what I think we see is even within a region, there's substantial variation. So if you look at chart 3.4, you'll see that in New Jersey, 11% of Medicare beneficiaries discharged from a hospital go to home health, but 21% of patients in New Hampshire are discharged to home health. Similarly, if we look at slide 3.7, you will see that Hawaii, and I think we already talked about how the number of chronic conditions was lower, but you'll see that they discharged by far the fewest patients to home health at 3%. And I think we saw earlier that home health was at 21%. So one thing to note also about Hawaii, and Hawaii is definitely one of the highest, Alaska as well, But if you look at this western region, what you'll also see is a lot of very high percentages of discharge home, discharge back to the community. So it looks like less formal use of post-acute care. So there continues to be substantial variation in how regions are using post-acute care services. And I think that's why you see organizations like CMS really pushing towards models like CCJR. And I think part of the goals of those models is really to reduce some of that regional variation. So this is actually something new that the Alliance did this year, and it's a new supplement to the chart book. And what it does is it shows state by state with pie charts. So we've inserted here excerpts from Connecticut and Oregon, for example. The data in the supplement really reflects this wide geographic variation in the settings for post-acute care at the state level. For example, in Connecticut, more than half of Medicare patients discharged from a hospital stay received formal post-acute care, and 18% of those patients were discharged to home health. By contrast, in Oregon, less than 40% of patients received formal post-acute care, and only 8% received post-acute care from home health, covered by Medicare. Despite, and those two states, interestingly, are actually similar in population size, but I think what you see is really, again, the extent to which there's such a high level of geographic variation in the use of post-acute care, but also in the types of post-acute care used. With that, I will turn it over to my colleague, Lily Hummel, who will walk you through the remainder of the chart book.
Thanks, Ellen. So we're now going to turn to section 4. This section shifts the focus from the beneficiary to the home health care workers. So if we start with slide 4.1, this is data coming from the Bureau of Labor Statistics at the Department of Congress. So what we see here is that after a decrease in the number of home health aides that are employed between 2010 and 2012, we actually start to see that tick back up in the last 2 years. So we'll have to see where this trend continues next year. Then if we move to slide 4.2, this is showing that the the Bureau of Labor Statistics is projecting approximately a 60% increase in the number of home health aides that will be employed in the next 10 years going through 2022. Again, as we've seen in prior years, slide 52, chart 4.3, is showing that the vast majority of those employed in the home health care services are female, so almost 89% are female, which is consistent with what we've seen in prior years. Next, we're going to turn to section 5, which are organizational trends in home health. If we look at chart 5.1, this slide shows that the number of home health agencies has been steadily growing since 1994 after recovering from a dip in the early 2000s. As of the end of 2013, there were 10,776 home health agencies, according to Medicare cost report data, about 8% of which offering private duty nursing. Then when we turn to chart 5.2, this is showing the breakdown of agencies based on the number of employees as collected by the Census Bureau. We can see that 30% of agencies are very small with 1 to 4 employees, and overall 90% of agencies have under 100 employees. So in general, the market tends to continue to have agencies that are predominantly very small. Looking at chart 5.3, the next data is coming from the Medicare claims file, and we're breaking down the number of home health episodes by whether they're covered by Part A or covered by Part B, and this allows us to see trends dating back to 2006. So we see here that the number of episodes covered by Part A has continued to decrease for the past several years. And likewise, we've seen a decrease in the number of episodes covered by Part B, although the number of episodes covered by Part B continues to greatly outpace the number covered by Part A, which means we're seeing more episodes from community-referred beneficiaries than those receiving home health directly from a hospital stay. Now we turn to chart 5.4. So whereas the last slide was showing the number of episodes, this slide is showing the number of Medicare beneficiaries that had a home health episode by whether the episode was covered by A or B. So in keeping with the prior slide, we see that for the number of beneficiaries where the stay was covered by Part A, there's been a decrease between 2011 and 2012, which held constant in 2013, whereas we do see an uptick in the number of beneficiaries with an episode covered by Part B in 2013. The number of beneficiaries with episodes covered by Part B could be increasing for a number of reasons. For example, beneficiaries might be exhausting their Part A benefit, or there could be an increase in the number of beneficiaries using the home health benefit who have not had an inpatient hospital stay, and thus the benefit would be covered by Part B, not by Part A. Chart 5.5 shows the number of beneficiaries with a home health episode by state in 2013. So, of course, not surprisingly, given geographic size, we see the largest volume in states we would expect to see it in Florida, in California, and in Texas. Alaska, Hawaii, and Wyoming have the fewest. So in total, in 2013, there were approximately 3.5 million Medicare beneficiaries who had a home health episode, which is about a 40,000 person increase from the prior year. Finally, chart 5.6 shows that the average number of 60-day episodes per home health user has remained constant from 2009 through 2011, but in the last 2 years we see the number of episodes per beneficiary using home health declining just slightly. So if we look at all claims, we see that in 2012 the number was 1.99 episodes, which dropped slightly to 1.96 per beneficiary using home health. Now we turn to Section 6, which is looking at the economic contribution of home health agencies. In Chart 6.1, we show the estimated economic contribution related to home health jobs in each state. This analysis is using state employment data for 2013 from the Bureau of Labor Statistics quarterly census. The BLS is collecting monthly employment and quarterly wage data from reports that are filed by nearly all employers in every state, D.C., and Puerto Rico. The reporting is mandatory for privately owned agencies, including for-profits and nonprofits. And in addition, several states voluntarily provide employment figures for their local and state-owned agencies, which are included in this analysis. So if we look at Chart 6.1, we see in the bottom right-hand corner that the estimated total number of jobs created by the home health industry is just over 1.8 million in 2013. Which is an increase of about 50,000 from 2012. To calculate the estimated number of jobs created by the home health industry in each state, we multiplied the number of jobs reported to the BLS by a multiplier that's provided by the Bureau of Economic Analysis. So this multiplier is intended to yield the total number of jobs indirectly or directly created by the home health industry. So even though the BLS jobs data do not include jobs for home health agency contractors, so that in each table, the figure on the left that's titled estimated number of home health employees, that would not include contractors. The multiplier is intended to account for that. So the figure showing on the right column, which is the estimated jobs created by the home health industry, that would include contractors. The multiplier is intended to capture the ripple effects of expenditures and demand. Moving on to Table 6.2, this shows the estimates of the indirect impacts of wages paid to each home health employee on total labor income in the state. So again, whereas the left column will be showing the actual number of the actual labor income, the multiplier is going to figure out the indirect effects. So for example, in California, we see that each dollar paid to a home health worker generates about 64 additional cents in terms of total labor income, as that employee spends his or her wages on goods and services. So in California, the estimated wages in 2013 were just over $2.5 billion, resulting in an estimated impact on labor income of about $4.1 billion. And then finally, if we look at chart 6.3, this is estimating the economic impact of home health expenditures on total economic output in the states. So this is taking into account additional jobs, wages, and other economic effects generated by the home health industry. So here we see a total economic estimated impact of approximately $72.9 billion. And the last chart in this section uses Medicare cost report data and BLS data to calculate the impact of home health on jobs over time. And so as you'll see, the number of jobs is continuing to decrease year over year, though I will say that the rate of increase has slowed. And now we turn to section 7, which is focused on home health outcomes. This section provides data related to outcomes among home health users. When we look at slide 7.1, using Medicare claims data, this is showing 30-day rehospitalization rates by selected DRG. So for comparison purposes, we show patients who first went from a hospital to a SNF on the far right column, as well as patients that were discharged directly from a hospital to home health on the left column. Overall, total rehospitalization rates for SNF patients is slightly higher than for those who received home health care, though I should note that this varies by DRG. I also want to note that this data is not risk adjusted beyond the adjustments included in the DRG coding groups. So for both home health and SNF, the rehospitalization rates continue to fall year over year for several years. In 2011, the overall home health rehospitalization rate was just over 19%, as compared to this year, or 2013's data that we're publishing this year, where home health rehospitalization rate averages 16.9%. And in SNF, that rehospitalization rate dropped from about 20% in 2011 to 17.49% in 2013. And this is consistent with the national readmission rates, which had been hovering around 19 to 19.5% for a number of years, and then it fell in 2013. The overall national readmission rate was 17.5. So that's very consistent with what you're seeing on these slides in terms of the readmission rates as well as the trends that I talked about. Charts 7.2 and 7.3 are new this year. These slides are showing readmission rates for DRGs 469 on this slide, and then on chart 7.3 for DRG 470. The reason that we're showing these slides this year is in response to CMS's proposed comprehensive care for joint replacement model. This is a proposed model that would begin on January 1st of this upcoming year. It's mandatory for all hospitals and 75 MSAs. We are expecting that CMS, if they move forward with their proposed timeline, would be issuing the final rule in the next couple of weeks, probably in late October, early November, so it's something to be on the lookout for. Assuming that CMS does move forward with the bundle as it's been proposed, it'll include all patients with DRG 469 and 470, including their hospitalization stay and all care provided 90 days post-discharge. So these two slides are showing, again, that both home health has, on average, a lower readmission rate than other post-acute care settings, and in most care settings in most years, you're also seeing a downward trend in the readmission rates. And finally, the next two charts are from the Medicare Home Health Compare website. Chart 7.4 shows the national averages for home health performance on certain process measures, which are measures that assess whether the home health care team has performed certain actions. So in general, home health agencies score very highly on these measures, and there were no decreases in performance over the years. And then chart 7.5 shows outcome-related data from Home Health Compare, which gauges whether or not patients experience certain outcomes during the course of their home health care. So again, home health agencies have measured either the same or improved ratings over time. So I think that's a pretty strong indication for the industry of their attention on quality. And so that concludes our summary of the chart book. As Ellen said at the beginning, I know that we did not go over every slide. This is all posted on AAHKI's webpage, so you're welcome to download the chart book, and this webinar will be posted if you'd like to take any further look at this slide or the supplement showing discharge by destination for every state. And so with that, I'll turn it over to Teresa for questions.
Great. Thank you guys so much. I thought that was very informative. I don't think that we have any questions right now, but I've got one that I wanted to ask, and it goes back to some of those post-acute market slides. So looking back at, I think it was slide 3.3, and maybe just comparing it to 3.1. I'm wondering if we can, oh, thank you. So I think you put, whoa, it's a lot of slides. Okay, so if you look at 3.1 shows total Medicare post-acute care expenditures, and what's interesting here is that you had a dip. 2011 it was $61.4 billion in expenditures. It fell in 2012 to $58.5 billion, but then it kind of ticked up in 2013 to $59.4 billion. And then in 3.3, what I find sort of interesting is that when you look at the total discharges from the acute care hospital, actually the total number of discharges went down, and it looks like, you would think that the expenditures would have gone down too, but actually it ticked up just a little bit between 2012 and 2013. It didn't go down. So I'm wondering, I know that the data is somewhat limited, but I'm wondering if you guys have any thoughts on what might potentially be going on.
Yeah, that's a great question. I think, first of all, one thing that's really complicated about this analysis and any analysis of fee-for-service is that we have Medicare Advantage enrollment constantly shifting at the same time. So in the case of, let me just address the hospitalization piece. So when we're looking at 2011 to 2013, when we see that reduction in hospitalizations, some of that is actually driven by the increased enrollment in Medicare Advantage. So there are fewer beneficiaries. So if we looked at per capita hospital utilization, you'd see it slightly down, but not down as dramatically as we see it here. And in terms of why we would see spending sort of popping up a little bit when we don't really see volume changing that much, I think there could be a bunch of different reasons for that, but part of it could be that in 2012, I think we still had some of those adjustments in SNF TPS, so it could be, sometimes we'll have like a one-time adjustment in a year. So it could be that, that we had some of that in 2012 and less in 2013.
That's interesting. I wondered how much might have to do with the readmission penalties that began in 2012, and whether there might be, tell me what you think. I mean, there could be a lot of things going on here, but I wondered whether or not maybe the total inpatient discharges might have gone down, in part because you've got fewer readmissions that might have been calculated in the mix as well, but that maybe you might have seen a little bit of shifting in terms of the cost in 2013, where maybe there was, because the penalties didn't go in until October of 2012. I wondered if in 2013 maybe there was sort of this feeling of we need to do something on the hospital's part. We need to do something to help support those patients after they leave our hands, so that we're working toward avoiding those penalties for readmission. and maybe that means, trying to shift a little more care into post-acute. But I don't know. I'm curious, what you think about that sort of, what the influence might have been of some of those types of policies.
Yeah, I think your point about readmissions is a good one. That may have also driven that top line number of the reduction in the total inpatient hospital stays. I think there's also been some, some increase of observation stays, so that I think you also might see playing out here a little bit. In terms of them really sort of focusing on post-acute care and post-acute care bearing more of that burden, I think that's certainly a plausible hypothesis. I think what's really hard now is that we don't have that clear, I think some of these alternative payment models are likely to really drive changes. So I think if some of the alternative payment models do what CMS would like them to do, I think in those state-by-state slides, we will see less variation. But beyond that, I think in every state, we will see there really being a focus on trying to, really have patients use less costly settings. So I think that certainly is something they want to achieve, and I think that's something that they're expecting alternative payment models to achieve, the clinically appropriate lowest cost setting. So I think then we might see some big changes. But I think what we're seeing in 2013 is we're not seeing that shift yet.
Right. That's great. I'm going to remind everybody that if you have any questions, you can enter them through the Fuse chat box. And also remind everybody that you'll have access to the slides after this webinar. I'm wondering if you guys are getting, feedback from your clients out in the field. What's the read on how quickly the marketplace is changing in post-acute care? You were just mentioning that, the alternative payment models are making a significant difference, but I'm wondering, since you guys are talking to an interesting cross-section of providers, both from, the acute care side and the post-acute care side, to what extent there is an awareness of sort of some of the geographic variation that happens, and also that maybe there are opportunities for clinically appropriate and cost-effective placements that might bring down overall Medicare costs.
So I think since the bundle payment programs focus specifically, the ones that we are talking about here, which are bundle payment for care improvement and the comprehensive care for joint replacement, those are two programs that they're piloting that really focus on the acute, post-acute period of care. There are other bundle payment programs that we're not talking about right now, things like the oncology care model that have sort of a broader perspective. So I think when we've been hearing from folks, it's mostly around Medicare fee-for-service. It's mostly for organizations that are participating in those programs or that are in markets that are participating in those programs. I think that's really where you see some activity, and I think a couple different things are going on. I think one is you're seeing narrow networks, which I think you probably hear about from your members, and I think many people on the phone have probably had that happen in their markets. Not in every market, but in a lot of markets, I think the acute care hospitals are thinking about who do we really want to be our clinical partners. So I think that's happening. And then I think they're thinking about, what is the best place to, and I think these conversations are really with the hospital and the physician groups, what's really the best setting of care for post-acute care. And so I think for us, it's been mostly in those markets where they've done the testing. I think it's about, if CCJR moves forward, that will be 25% of all hospitals in the U.S. So then I think you really potentially would see a shift. Since BBCI got a little bit delayed in some of its implementation, I think we probably won't see much of that until 2015. But with CCJR in 2016, I think you'll see, if CMS does indeed implement January 2016, I think we will really see a lot of thought and change at that point. I don't know, Lily, if you have anything to add to that.
No, I think that probably covers the state of what we're seeing.
Okay, great. So I think I've got one more question, and that I can ask while we're waiting to see if there's anybody who has any other questions. You mentioned Medicare Advantage, and I think I've been seeing just sort of recently some studies that were published about Medicare Advantage, and there being a lot of shifting between fee-for-service enrollment, sort of traditional fee-for-service Medicare enrollment, and Medicare Advantage, and that what you sometimes see is that when Medicare patients might be a little bit healthier, they're in those Medicare Advantage plans, but they might be switching to traditional Medicare if their condition worsens. And so I'm wondering, what you think might be the impact of that kind of shifting between MA and traditional Medicare, and how you think that might have an effect on what we're seeing, because we're really only looking at the fee-for-service claims side in this data.
Yeah, so we are only looking at the Medicare fee-for-service population here. So those would be the folks who, I think there was a recent study where they showed that some beneficiaries are shifting out of MA to fee-for-service. But I think that sort of there's two big things happening. One is Medicare Advantage enrollment's increasing. And I think if you look at the latest estimates from the Congressional Budget Office, I think they're estimating by 2022 it'll be 40% of all Medicare beneficiaries. So that's really, we're at 31% today, so it's really a substantial program and a very big program. And I agree with you, Teresa, it's really important to understand how beneficiaries who are sick are sort of, doing in that program, and are they shifting back to fee-for-service? And there was that study recently published that suggested they were. But I think in terms of what does that actually mean? Well, as more and more beneficiaries enroll in Medicare Advantage, I think, if it is the case that you end up with sicker beneficiaries in fee-for-service, it obviously has really big implications for organizations that are trying to form ACOs and, really trying to manage under sort of risk-based contracts if they're ending up with the sickest of the sick versus sort of a more generalized population. So I think, that was a really important study. I think there's definitely going to be more to come on that, because I think there was a very big reaction. But I do think it's a really good question that if we get to the point where our Medicare Advantage is 40%, which is really substantial, what does that mean for fee-for-service? And I think there's certain markets already, if you think about Southern California, Minnesota, there are other markets that are already very heavily Medicare Advantage. And so I do think that the experience in those regions is probably informative for the rest of the country.
Thanks so much. That was really helpful. We're not seeing any questions from our audience. So I just want to thank you both, Ellen and Lily, for doing such a great job. I want to encourage everybody who's listening to this webinar to definitely check out the full chart book and the state-by-state supplement that's on inpatient discharge destinations. I definitely wish and hope that everybody makes good use of that data. Our goal with the chart book as an alliance is to make sure that we're providing both the home health community and the general public with really solid information about home health care. And as we talked about at the top of the hour, this is all data drawn from government sources, and so we're looking to make sure that there's a strong understanding of the role of home health care and that we understand it through data. So with that, thank you very much, Ellen and Lily. And if anybody has questions, I think that their contact information is in their slide deck that we'll post. And you can always also reach out to myself, Teresa Lee, or Jennifer Schiller at the Alliance. And I hope each and every one of you has a wonderful afternoon. Thank you so much for joining us.